Okay, so everybody, I'm here with Ken Woods, infectious disease consultant at Trinity. And Ken has approached me that we're having some issues with soft tissue infections and cellulitis and abscesses down here in the ED as far as how we're managing them after we do IND or after we see them the first time. It seems as though, and Ken, correct me if I'm wrong, but and then I'll let you get started. We're seeing a soft tissue infection. We're doing incision and drainage. We're giving a dose of vancomycin and send the patient out for follow-up within 24 hours. And go ahead and tell us what's wrong with that, and then we'll go ahead and keep going.
Yeah, a couple of the cases that I've seen recently that have come through and been admitted have presented to the ED with some form of a soft tissue cellulitis or a pustule draining abscess, or even an abscess that then was IND'd and sent for cultures. The localized care, and I think the initial care, was all perfectly within the scope of standards of practice. Many of them were given IV vancomycin, suspected community-acquired MRSA, or maybe even histories of MRSA and skin infections, adequate coverage, great agent, to start off. The problem really is then after the IND is done, or if there's cellulitis without a drainable collection, that single dose isn't followed up by additional antibiotics. So in a young, healthy patient with normal renal clearance, the vancomycin is then washed out probably over the course of about 8 hours. So if they're told to follow up, in some of these cases 24 to 48 hours later, if they're not followed up with an additional dose of something, in 8 hours they're on no antibiotic therapy. So if there's an IND, at best their lesion is draining or packed with iodoform, but if it's a cellulitis, a non-drainable collection, they're essentially 8 hours on an antibiotic, and then the next 24, 36 they're on no antibiotics, and when they follow up they usually are worse. So I'm not surprised when some of them come back and are worse, but I think the crux that we can make a little intervention on in those particular scenarios is that interim. So after they've been deemed they need empiric MRSA coverage or they warrant an IV antibiotic, is either following that up with an additional IV however they need it, whether it's coming into an outpatient center for infusion, or if it's admission, or if they're of a lower acuity where they could be de-escalated to something oral, even continuing coverage for MRSA, doxycycline, Bactrim, Clinda, whichever varieties, based on the patient parameters, that then they would continue to take once that 8-hour window of vancomycin's worn off. So they then, when they present back in 24 to 48 hours, for a wound check or maybe an iodoform packing change, they're not 48 hours completely off antibiotics, but yet converted from an IV antibiotic to potentially the orals, and then gives you that ongoing coverage.
Yeah. So the takeaway point, there's a couple points we want to make is, number one, if you have somebody with like an abscess, a collectible abscess, or cellulitis that you feel like needs a dose of IV antibiotics and could probably go home because they're not toxic or have evidence of sepsis, we really need to put them on some form of coverage prior to the follow-up. So they get a dose of Vanco, we put them on Clindadoxy or Bactrim, have them come back in 24 hours to be rechecked so that they're essentially not off of antibiotics, like because of the pharmacokinetics of vancomycin. The other thing is that just the cellulitis diagnosis without a collectible drainage, somebody who might have like a diabetes or peripheral vascular disease and have a cellulitis of the leg without an elevated lactate or without instability of the vital signs or high fever, and you want to give them a dose of medicine and send them home. What are our choices at that point? We have we want everyone to know that cellulitis admissions are pretty much a losing proposition for the hospital. So if we can treat them as an outpatient, we're going to save the hospital a bed and money and etc. So our choices are then we could use Orbactive, or we can do the dose of Vanco and oral medication and short-term follow-up, like 24 hours or less, to see if we're getting improvement. Why don't you talk about Orbactive and how it can be a benefit to us?
Sure. So we have, just to quickly mention, we also have a couple other IV options as well. If someone has Vanco allergies or no histories of MRSA and you're suspecting more of a strep process, Cefazolin is wonderful for strep. Unison is also good for some of these guys without MRSA history, especially when it's a diabetic chronic type of ulceration with anaerobic and polymicrobial flora. Those are also available IV that should still be followed up with another agent if they're deemed a candidate that's not toxic and being dispositioned to home. So there are alternatives. I don't want to, belabor that Vanco is your only option because there certainly are many. Vanco obviously the most common because it's covering most of your cellulitis pathogens.
Okay.
As far as Orbactive, I think we're just now adding it to formulary as a CHI alternative to our prior agent dalbavancin. But Orbactive is essentially a longer acting version of vancomycin. You can think of it in a nutshell as vancomycin molecule attached to a protein that then is a single dose, but its effectiveness lasts for 10 to 14 days. So in the trials, they usually either compare it to vancomycin IV twice a day for the 10 to 14 days, or linezolid, which is equivalent IVPO bioavailability for the same duration, and it's non-inferior. So it's like giving somebody vancomycin twice a day for 14 days, but it's a single one-time infusion. It's only approved currently for soft tissue, cellulitis infections suspected from gram-positive organisms, which is what vancomycin is essentially doing. So it does cover MRSA, it does cover all of the strep species, and is a very good fit for the cellulitis patients. In the future, it'll have some additional indications that are in the pipeline for FDA. In the future, I would suggest we could talk in more details about a protocol with Orbactive, but the biggest benefit that it can definitely give the patients is it's an IV therapeutic option that lasts for 10 to 14 days despite it's a single one-time infusion.
And the cost on that is about?
The cost is around $2,000 for the dose, which is a big end on the pharmacy side to make sure that we're able to solidify the reimbursement process so that we're not accumulating the cost of those because they quickly add up. I think we have some on hand or are currently purchasing some. The hardest part is we can't use it on inpatients because every insurance across the board is going to deny it or refuse it on an inpatient status, because its sole niche really is to keep patients away from the inpatient setting. So its main use is in the ambulatory infusion centers, emergency rooms, potentially urgent cares, and then we're looking at it in here within Trinity with the 5, the clinical decision or observation unit is how we can utilize those patients that are non-toxic and here for potentially a 23-hour obs type of stay, benefit from that infusion, and then proceed with outpatient follow-up.
Sure. Is there any contraindications to Orbactive, like renal function or anything like that?
There is some with renal function. There's also the initial phases. It was thought to interfere with heparinization. So folks that were on heparin products or within the last, I think it was 24 to 36 hours, received heparin products, as well as with Coumadin. But it's thought now that it's more of an interference with the INR assay. So it's not a complete contraindication as it once was. So those are definitely changed within the last, I would say, 6 months or so.
So we'd have to make sure their INR is checked throughout the 10 to 14 days. That
so if it's someone that is a Coumadin-ized patient, they certainly, whoever's managing their Coumadin would need to be aware. If they're having their levels checked, the numbers we obtain on their INR may not be valid for the actual number of their anticoagulation status. So it's harder to interpret, and I don't know that we have a algorithm to fully interpret that as opposed to the symptom monitoring.
Okay.
It's not thought to interfere with the absorption or the metabolism of Coumadin, though.
Okay. The one of the biggest things that we deal with down here is follow-up with patients. So after we do something, we don't want to lose control of the patient to follow-up, where they don't get follow-up and end up having a bad outcome because they weren't seen appropriately. So, we talked about the wound center with giving follow-up care, but sometimes they're not really available immediately after we would do an IND, like maybe the next day or maybe even within 5 days. We hate to have people keep coming back to the ED because it can be an expense for them. But at least, we should touch base with the wound center, I think, for follow-up, the family physician for follow-up, maybe Dr. Coleflesh's transition care clinic for Trinity patients for follow-up, and then certainly using ourselves here for a 24-hour recheck, whether it's the Vanco plus another antibiotic or if it's the Orbactive that we gave here in the ED to try to avert an admission to the hospital. Thanks a lot for talking to us about it, and we'll get this out to everybody that's on staff, the nurse practitioners and physicians, And I appreciate you giving us your concerns that some of this stuff is falling by the wayside down here. We don't want to be one of the problems.
Sure, I'm glad to help.
Here.
You guys know you can always call me. Anything I can do to
That's right.
assist.
Thank you. Okay.